Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Shamar Young. He's a physician executive. Today's Kevin MD article is Geographic Disparities in Advanced Cancer Care, a call for innovation. Shamar, welcome to the show.
Thank you for having me. It's a pleasure to be here.
All right, let's start by briefly sharing your story and journey.
Yeah, so I'm an interventional radiologist, and some people may not be familiar with the fact that interventional radiologists are commonly treating cancer, especially liver cancer. And one thing that we've seen as interventional oncology, as we like to call it, has evolved is that there are a lot of disparities between how patients are treated depending on where they happen to show up to clinic. So patients that are treated in New Hampshire, where you're at, may be treated very differently in Tucson. And a lot of that has to do with just resources that our various systems have. And so that's really what our article talks about and explores.
All right, so talk about the article itself for those that didn't get a chance to read it.
The article really explores how a individual patient's journey can be very heterogeneous depending on where they happen to present with whatever problem that they may have. Our focus was definitely on cancer therapy. However, this can be true in many different aspects of modern medical therapy. And it's easy for people just to have knee-jerk reactions of, oh, that doctor's bad, or oh, that system's bad. But that's not actually what's happening in most of the cases. There's a lot of complex things that happen in the modern American healthcare system that affects how people are treated and what kind of care they get, what level of care they get. And there are a lot of challenges for us, and we just kind of explore the various challenges that the medical systems and individual physicians have and some options to try to overcome those.
So, what will be some examples of these geographical disparities where patients who need interventional radiology procedures for cancer care would differ based on where they live? What would some be examples of conditions and procedures we're talking about here?
Yeah, so for instance, if somebody presents with hepatocellular carcinoma, which of course is just the most common primary liver cancer, if they present to a large center with a strong IR presence, many of those patients, if not most of them, will be treated up front with something we call local regional therapy, which of course just means we're going to try to treat the cancer there in the liver. If they happen to present to a low population system, then they may not even hear the word interventional radiology at any point. They may just hear systemic therapy, maybe a surgical therapy if they're a candidate. Unfortunately, very few patients are candidates. And then maybe transplant if they're lucky. Even if they hear the word interventional radiology, one of the most common treatment methods at this time is something called transarterial radioembolization. Using that it sounds like a very succinct thing, but as we all know in the medical field, the devil's in the details. And so how the radiation that is to treat the hepatocellular carcinoma is prescribed can vary greatly between providers and between systems, and whether or not the system happens to have the software that they need to do advanced dosimetry and try to optimize outcomes for those patients. It's very heterogeneous across the country.
So, give us a sense of the impact on patient outcomes if you have patients in different geographic locations undergoing different treatment algorithms. How does that impact outcomes?
Yeah, and so, one of the trials that we'll often look at in interventional oncology, again, is a radioembolization trial. It was called DosiSphere. And really what it showed is that if we use these advanced dosimetry techniques, that the benefit can be over a year, and the overall survival benefit can be over a year. And that many more of these patients can be what we call downstage to curative intent surgery if they do have the advanced dosimetry. But while it's hard to get a feel for how much advanced dosimetry is really being used, one of the markers we can sometimes look at is Medicare data and who's billing for advanced dosimetry. And we see that less than 1% of all IRs are billing for it. And so this kind of lends us to believe that there's quite a bit of heterogeneity between them. Of course, many interventional radiologists may be performing advanced dosimetry and not billing for it, but we'd say that's probably going to be a minority of physicians.
And you alluded to this earlier, but in terms of the reasons why there's such heterogeneity, is it because of cost, because of training, and you can't get interventional radiologists in rural areas? What are some of the factors that lead to these disparities?
Yeah, it's a great question. I think there's really two reasons. Exactly as you're alluding to, interventional radiologists are a small subspecialty, and there's just not enough of them to go around. And so they tend to be clustered in larger hospital systems and larger population centers. And so many of these rural hospitals can simply not hire anybody because the demand is too high, and those may be considered less desirable by some physicians that are leaving residency and looking for jobs. Another factor is just the resources that an individual interventional radiologist and system may have available to them. It's easy to say, hey, just get that software, but we all know that all systems face a lot of demands with very limited resources. And so if perhaps you're only treating one patient every other month with this treatment, it may not make sense for your hospital system to invest in a software. And so that can lead to some differences in treatment patterns.
In your article, you talk about some of the lessons the U.S. healthcare system can learn from European models of centralized, specialized care. So, talk about that contrast.
Yeah, in Europe, as I'm sure many of your listeners are aware, they tend to have centers of excellence. And so they will send everybody with HCC to one or two centers within a particular European country. And that is an excellent model for Europe because it really does allow patients to get a more homogeneous treatment algorithm. And it concentrates patients of a certain diagnosis within a center, allowing that center to then optimize their resources and really invest for that disease, all of the special bells and whistles, for lack of a better word, for that disease. The problem we have in the US is that we are so large geographically that it's really tough. I mean, just frankly speaking, nobody in Tucson wants to hear, hey, you need to go to New Hampshire to receive treatment. That's where the Center of Excellence is. It's a financial impossibility for many of my patients and a huge burden for even those who have the economic means to do it.
All right. So, what are some paths forward to address some of these disparities in the United States?
I think a lot of people are looking at third-party vendors to try to close some of the disparities when you have the physician. So there are third-party vendors where you can concentrate certain steps of various treatment algorithms, the dosing, for instance, and radioembolization can be concentrated with a third-party vendor. And it reduces the entrance cost and the overall cost to a system if you're not doing so many. In terms of physician availability, it is a real challenge for a number of reasons. One, there's just not enough. And frankly speaking, the statistics tell us that the shortage of interventional radiology, just because I am an interventional radiologist of great interest to me, is going to increase rather than decrease over the coming decade. We're not training enough right now. We can hope to increase our residency spots, but those are really long-term issues. The other factor that many systems are placing is that, again, interventional radiologists are a small subspecialist. So if you're a small community hospital in a small population center, then it may be difficult to justify having an interventional radiologist because there may not be enough work for them to do on a day-to-day basis. And so I think those are the challenges that are going to be harder to crack, but we will continue to move forward. And, various models such as interventional radiologists showing up to a certain small, low volume center hospital once a week, twice a week have been explored, and hopefully will provide some benefit.
Now, help me understand that role of third-party services. So, give us a case study, story, or scenario where a third-party service can address some of the expertise shortages. So, what would that look like?
Yeah, so in the case of radioembolization, we've been talking a lot about dosimetry because it's a personal passion of mine. And so advanced dosimetry requires time, requires a software program, and it is one of those situations where, again, if you're not treating tons of patients, if you're not using that software every day, the time that it takes for you to do the dosimetry aspects increases quite a bit compared to somebody that is using it every day. And so that's something that can be offloaded to a third-party vendor. The third-party vendor can use the program, return the case with segmentation and all of the details that are required to be inputted into the program. And then the physician can work with that and relatively quickly choose a dose or optimize a dose for that patient. And so that can lower your barrier in a number of ways. It can reduce physician time and it can reduce the hospital's cost because they don't have to upfront purchase that software, which can be expensive.
Anything from a systemic or policy standpoint that can decrease these disparities?
I think the it's really challenging, to be honest. And I think all of us are hoping for and looking for a magic wand. And, to the best of my abilities, I have not personally come up for one. Of course, we can incentivize physicians by increasing revenue for those that are doing certain things like advanced dosimetry. But to be frank, many of these physicians have a lot of relatively quote unquote high RVU activities that they could be doing at any one moment. And so it only goes so far. In terms of trying to increase the number of specific specialty physicians that are trained in interventional radiology is just one example of many, as you and your listeners are well aware of, that we could probably benefit from an increased number of those physicians. That too is challenging. It's hard sometimes to just increase the publicity, so to speak, of that specific subspecialty. It's even harder to train people quickly. Residency is at least 6 years. And so, of course, everything takes time. But these are things that we could look to. That said, I honestly, I wish I had some great idea that was a magic wand, but I think it would be disingenuous to say I do.
We're talking to Shamar Young. He's a physician executive. Today's Kevin MD article is Geographic Disparities in Advanced Cancer Care, a Call for Innovation. Shamar, let's end with some take-home messages that you want to leave with the Kevin MD audience.
The things I would like to say are really twofold. One, I think that in modern American society, it's very easy to demonize certain entities, but many of these issues are very, very complex. So again, it's not necessarily that any physician is bad. It's not that any system is bad. It's that they're facing real challenges, and we should at least try to understand those. The other thing I would like to say is that there are many people aware of these problems and working to find creative solutions. We could always use more people trying to find creative solutions. So would love to have anybody out there that has a passion for this to jump in there, but creative solutions are needed.
Shamar, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thank you for having me.